and welcome to a very special edition of the Journal Club. Today we'll be discussing the issue of women in cardiovascular disease based on the Lancet Commission and publication. Today's speaker is Giulia, interventional cardiologist from the University of Padova, and I'm delighted to say that as experts we'll be joined by Professor Alaide Chieffo from San Raffaele in Milano and Professor Roxana Mehran from Mount Sinai in New York, both of whom were involved not only in this commission but also in the publication. So I hope you enjoy this special edition. We look forward to receiving your feedback and, as always, your participation. Thank you.
So I'm really proud to present the report of the LANCET Women and Cardiovascular Disease Commission in the presence of Professor Mehran, which coordinated the work, and Professor Chieffo, which has been frequently involved in gender issues. But first of all, what is Lancet Commission? Stuart Spencer, the Lancet Senior Executive Editor, explained that the journal has developed over 60 commissions on clinical and environmental topics to identify critical problems and provide a framework of research to solve these issues and to improve healthcare. But why women and cardiovascular disease are critical issues? 35% of all deaths in women worldwide are caused by cardiovascular disease. And in socially deprived regions, women have even higher mortality than men. In high-income regions, the decline in cardiovascular disease mortality has slowed down, and cardiovascular disease mortality has increased in women from certain countries. But most of all, studies show that there is an increase in myocardial infarction in young women. Moreover, women are still underrepresented in clinical trials and undertreated, and many cardiovascular risk factors are still under-recognized and associated with social and physical environments. The COVID-19 pandemic has been a strong reminder on how gender-related factors can interact to negatively affect women's cardiovascular health. So the aim of the Commission was to summarize the existing evidence and to identify the knowledge gaps in cardiovascular disease research, prevention, treatment, and access to care for women, to reduce the global burden of cardiovascular disease by 2030, aiming to gender equity and equality in cardiovascular health. We can identify 6 main sessions of the article, starting from the presentation of the results of the latest global and disease burden, and moving to the discussion of the major cardiovascular disease risk factors and the major cardiovascular disease, and a description of cardiovascular disease burden in women by region. And after listing the limitations of the article, the Commission finally presents the practical recommendation to reach their goals. The Global Burden of Disease study was produced by the Institute for Health Metrics and Evaluation, and showed a stagnation in the reduction of cardiovascular disease prevalence in women since 2010, and even an increase in East Asia, Western Sub-Saharia, and Oceania. Moreover, the study showed a concerning slowdown in the decrease of cardiovascular disease mortality in women over the last decade, with no significant change or increase in Central Asia, Sub-Saharan Africa, and Oceania. Understanding the different factors contributing to this patchwork is particularly those under-recognized, as unemployment, social economical disparity, cultural status, and religious norms. The Commission therefore presented the main cardiovascular disease in women, highlighting that ischemic heart disease was the primary cause of cardiovascular disease mortality in women worldwide in 2019. A dedicated session of the report offered region-specific recommendation. For instance, in Europe, smoking and hypertension remained main concern because of a relentless increase in smoking in women and higher mortality risk attributable to hypertension in women than men. The following limitations should be acknowledged when reading the article, because we cannot exclude a bias towards highlighting evidence for sex-related differences over reports of neutral findings. Moreover, there is only mild emphasis on the difference between sex and gender, and the article did not address cardiovascular health in transgender women. Moreover, the overall evidence presented in the article might be dominated by data for white women and high-income countries, but that's what we have. And the level of evidence for the different sections varies substantially. Finally, I listed the top 10 recommendations of the Commission to close the knowledge gap, to increase awareness, and to improve prevention and care in women. Those strategies include direct finding for accurate data on prevalence and outcomes of cardiovascular disease in women globally. Moreover, the development of educational programs, both for physicians and communities. Moreover, we should prioritize sex-specific research and develop strategies to include more women in cardiovascular trial, as the panel show. So we should be inclusive, exchange knowledge, and meet women where they are, and moreover, remove barriers. Moreover, we should prioritize funding in global health organization, especially from socioeconomically deprived regions. Established initiatives to reach early detection and prevention in settings frequented by women and involving especially young women. Moreover, we need research on cardiovascular to understand why and which risk factors impact on cardiovascular disease. Finally, the final recommendation of the Commission was to scale up healthy heart programs in highly populated and progressively industrialized regions, and to embrace public-private partnership to develop broad-scale programs. So I have finished my presentation of the report, and I leave these open questions to our expert. Will 10 years be enough? And which recommendation will have a greater impact in industrialized regions and for young fellows? And how technology and social media have a major role in reducing gender disparity. But first of all, I leave the floor to our expert discussant to listen to their main considerations about the presented topic. Many thanks.
Great. Thank you very much, Giulia, for that nice summary of this very important piece of work. I think it leads nicely on to, if I can invite Professor Roxana Mehran, if you could give us some of your insights into this work, how it was to actually conduct this work from an academic point of view, and the main messages for us young fellows.
Well, first of all, when I was asked to lead this commission, I was I was, of course, really excited. You know, it's always like this, right? You get this wonderful like opportunity and you just think to yourself, oh my God, me. And the first thing I have always is this imposter syndrome. Like, am I good enough? Am I going to be able to do this? And I think that's a problem of all of us women thinking that, oh, we're just never going to get this done. But then I dug deep and I said, no, we can get this done. And how do I organize something like this? I mean, can you imagine to be told by the editor-in-chief of the Lancet that this is one of their biggest things? And then they showed some examples of what they had done in the past. And the example they showed me was this commission on food and substance of food around the world. It was like unbelievable, so beautiful, so well done. I just was like, oh my God, we're never going to get to this, you know, this level. But then I kind of, you know, sat back and I started to think about in my head, organizing for all these decades. So much has been done and we keep talking about gender disparities, heart disease in women. Everyone and their mother has a heart disease center for women and everyone is doing, but why are we not making an impact? And it was really making me kind of dive deeper into understanding what are some of those important issues. And then, of course, the big part of this was teamwork. It wasn't about me. It was about who can we bring to the table that has now, there were many, many things. The Lancet is extremely strict about having, they chose a lot of the commissioners, but also what they wanted was not just all the senior people that we all know, but rather the unknown faces. So the commission also gave faces to the women who led the commission, who previously none of you would ever have known who they are. And I thought that that was a bold, wonderful move. I also felt very, very strongly that the commission needed to, you know, have the young represented. And I don't know if you all have noticed, but the first author of the commission is a fellow who was working with me. And, you know, it was a big decision to do that, right? I mean, here is my opportunity to be the first author of this commission and be all over there. But I felt like, well, no, this is exactly what we're supposed to do, is to give to the young, incredible, hardworking, and they would be doing all of the work. I mean, a lot of the work was done by Brigitte, who's amazing. You should get to know her. She's an amazing, amazing force. She did so much of the work. She's so deserving. She is absolutely the first author of this commission for all of the hundreds and thousands of hours that had to be put in to actually organize and figure this out. So I really took more of an organizational role and, you know, keeping things into a thought process as far as like kind of making everyone, because you could go crazy. People started writing chapters and you can't do that. You have to be concise, but also accurate and also very, very much with a directive of what are the gaps and what's the recommendation. No more complaining. How do we change it? How do we close the gap? And we had to keep meeting in person, bringing everybody together, and everybody kept going in these directions. And we had to keep coming back and say, no. Go back and redo this because it's not a review article. It's about you looking at the data, seeing what the gaps are, and coming back. So it took a long time. It took like 4 years to put it all together. It wasn't, you know, and it was a huge effort by so many people. We raised funds to be able to travel all of the commissioners because we felt like it couldn't be really, well, Zoom really wasn't really existing back then, but still, even with phone calls and these like getting together, it's not the same as being in the same room, drawing on the board, coming up with ideas, saying no, yes, all this. So we did a lot of that. And then, of course, the thing that hit us, this was supposed to be the 2020 vision. It was supposed to come out in 2020. And then there was this huge pandemic. So we couldn't we couldn't do that. But to get back to the science, when you do a commission like this, is you have to review the science and not regurgitate it back, but rather talk about, well, yes, here's the science, but here are the gaps. And now, how do we come up with a recommendation? And remember, the gaps are different in different regions of the world, right? I mean, I can say we should be doing IBIS and OCT, but that doesn't work in sub-Saharan Africa. And it doesn't work in places where there is no access to care. Maybe for those people, it's just about their salt intake. Maybe for some people, it's about diet and exercise. Maybe for other people, it's about stopping smoking. And these technology driven, and especially as interventionalists, we had to keep people a little bit more simplified. Be simple. Think about small changes that can make big differences. That's how you close gaps. You don't close gaps by saying, oh, let me like completely redo the entire system of STEMI care in the world. That is impossible. You have to look at the low-hanging fruit, you know, the fruit that's in front of your face, and you just have to pull it and eat it, right? And so those were the kinds of things that we had to do. And we had to keep thinking and rethinking. And so it was a pleasure to have Professor Chieffo with me as one of the commissioners, as well as 17 of us. And it just so happened to be that it was all women. And yes, of course, my first question by anybody was, why did you choose all women? And I said, my answer is, why is it no one has ever, for decades, ever questions, why are these all men authors of all these commissions before? So please don't ask that question today, because you will get a difficult answer back from me. And so it was so that everyone understands how women feel, as they've always been excluded from so many of these important. If you go back to the commissions, they're mostly led by men and mostly all male authors. And so and you know, the other big part of this, and the thing that I would like to change, and this is something that Professor Chieffo and I have talked about, is that the experts for cardiovascular disease in women, for some reason, are women. How many of the men here on this call, on this Zoom, how many of the male fellows on Young GZ actually care and love to understand gender differences in men and women for heart disease? How many of you have written and spoken about this in an abstract or written a paper? How many of you have clinics that takes care of women? The answer is 0. I'm sure of it. Nobody is saying anything, but I'm certain of it. And so it kind of was not just because we were only looking for women, but the experts, we didn't just choose them because they were women, because they were qualified experts in the arena. And so the one big thing, if we want to make a change, is to get more men, young men, interested in taking care and understanding gender differences. This is all social, societal issues that everyone is running away from. It's boring. This is about men, gender differences. I want to talk about bifurcation stenting. I don't want to talk about, Anoka, because I can't put a stent in it. It shouldn't be that way. We should change the way we're thinking and get you guys to start to recognize better the differences of how women are presenting with an acute myocardial infarction. How important is imaging, physiology, microvasculature in women? How important it is to understand the pathobiology of what's going on in women. That's coronary disease. On the valve side, more than 50% of the valves are usually, the TAVIs are in women, but their physiology is different. It's different than men. And we need to understand what those changes are. And we're doing a trial right now of SAPIEN versus CoreValve in small annulus, still 90% of these patients will be women. So let's not be thinking as a taboo that if it's a woman issue, I don't want to be a part of it. It's not fun. It's not macho. It's not great. It is great. It's great science because half of the population of the world is women, and we need to save them. And the only way is to get men and women together to work together to deal with this issue of the problems that are happening. So I think I spoke too much, but anyway, because you get me going, I get excited about this area. So these are some of the high points about the wonderful honor of leading this commission.
Thank you. Honestly, I don't think anybody would say talking too much. Really, really insightful. Thank you. Professor Chieffo, from your perspective, I think on a different scheme, moving forward, what are the key, let's say, practical steps that young interventional fellows, young cardiology fellows, in fact, should take to make sure that we do not repeat the mistakes, let's say, of the past, and we think and we work and we learn in a different way, as Professor Mehran has just pointed out?
Yes, first of all, I would like to thank Roxana to have put me in the commission. It was a great honor, and honestly, I learned so much. I mean, if you read all that document, there is so much that you can learn being a Western cardiologist and understanding what's going on in the other part of the world, because that's another point. We are always talking about Western world, industrialized countries, but there is a majority of the world is not having our issue. They have other issue. I mean, we learn a lot, control of risk factors all over the world. And as Roxana was saying, Professor Mehran was saying, there are countries where they cannot afford even to measure the arterial pressure. So they don't even know they have hypertension. They are measuring in the church in the Southern America. And people have to come up really with out of the box ideas. And this was very fascinating. From your perspective, I mean, I know that Giulia, by the way, has a great interest on the topic, and Giulia was showing the second year of Giulia Women, or it is something that we did last year. We are going to repeat and going into female-specific disease, because we do have this. That's another point of the story. Last year, it was published the INOCA consensus document, and this is getting more popular. I mean, in ischemic heart disease, we have women presenting with chest pain that were absolutely ignored, because it was said we were doing only coronary angiogram and tell to them, okay, you have nothing. So maybe it's some psychiatric disease that you are having. And indeed, we learn that it's not like that. It's just another kind of ischemia induce pathology, and you can do your diagnosis in the CALAB with the coronary physiology measurement, and you can come up with the diagnosis and you can come up with the therapy. So from your perspective, from also reading that big work that was led by Roxana, and also look into the literature, you have to have another glimpse to the problem. Just don't stop to what is sometime in the surface. Women coming to your clinic and say as a chest pain, and you just stop from coronary angiogram, or Minoca, women coming with troponin elevation, but again, non-obstructive coronary artery disease. There is a big clinical need. There is a lot of research you can do. And I do think that in this female-specific disease, there is a lot still to be done, from coronary to structural heart disease, as Professor Mehran was mentioning.
Okay, thank you. Now is probably a nice opportunity. If anybody joined on has any questions about, let's say, the field, the paper, the commission, we have to global experts who've spent an awful lot of time working on this. So if there's any questions from anybody, please feel free to speak up.
Just one question, turning to my previous opening question presented before. which recommendation do you believe will impact most for young fellows? For example, to increase awareness in young fellow about this topic, using social media, using technologies, what we should do practically.
I think that's an excellent question. And I'd love to hear, I'd love to have, an idea, ideas always pop into my head when these things come up. And an idea in my head is that, wouldn't it be great to have a think tank with some of the young people, especially with the GZ Young, and that you guys think about how in the modern world we can reach more people to make more awareness. Not more people, especially more physicians, more cardiologists. Now, I don't know if most of you are interventional cardiologists. The idea is not just about interventions. Maybe we need to also get a closer relationship between GZ Young and the sick young, as the Society of Cardiology Italian, the sick. So is it sick? I don't know the name of it, of the society, the society at large for cardiology. And then getting this whole young group into a think tank where you guys come up with innovative approaches and ideas that then can be implemented using social media, coming up with some kind of a great branding. The commission is going to continue for the next 10 years. And we could get funding around some of these things to help support some of the work that's being done in terms of the think tank that we could put together, where you guys come up with the ideas of entering the world. Like, how do we use some of the social media for awareness and for teaching, perhaps, and maybe setting up cardio-oncology clinics, maybe setting up high-risk pregnancy clinics in understanding and picking up some of the risk factors there. Maybe working with some of the cardiologists to think about some of the unusual presentations of acute myocardial infarction. Maybe having symposia and having like a social media outlet that basically talks over and over about, oh, did you know that this normal coronary in this woman who just had a acute myocardial infarction had a coronary dissection that wasn't shown on the angiogram, but actually we made the diagnosis by X, Y, and Z, whether it was OCT or something else. I don't know. How do we, the ideas are tremendous, and the thinking of what you guys could do to connect the world, the old way of thinking and the new way of thinking, the new way of transmitting information. Especially now in the post-COVID world, social media becomes a much, much bigger outlet to connect the world. So those ideas are very welcome. And we have, and we do it all through the commission. You don't do it on your own. We do it through the commission, and it becomes a commission project that you could propose to us. And then if it's really good, we would get funding for it and make it go ahead. So I do think that you are the bridge to the future. You are the future. And we need to figure out, how do you disseminate this? Like, having sessions and putting journal clubs like this one to be shown, where everybody brings a case of a woman with coronary disease and shows how it went, some funny dilemma that happened, something different. Those things are all very, very welcome, because it raises awareness and doesn't make you feel like, oh, this session is about women, I don't want to go to that. That's what it used to be in the past. We used to make all these efforts, and we would have these gender sessions, and it would be the audience, would be the people who are speaking and the commentators, and that's it. Nobody would come. And so then they would say, oh, these are not popular sessions. They're not popular because it's not like, you know, exciting. But we tell us how we can make it exciting for you, the next generation that needs to treat these women. And then it could be in prevention and intervention. So the younger people can talk about the prevention stuff. And you guys, the younger people in the sick, and you guys could do that. And then in sick, you have heart failure, you have EP, because this isn't just about STEMI and putting stents quicker, faster in women. This is more about, you know, a really like, it's a grassroots movement to kind of think about this totally different.
Yeah, really, I think there's a lot that we can do, and thank you for being, let's say, so open and collaborative with us. You know, something as simple as like a series, 3-part, 5-part series addressing this little topics, maybe the subtopics that we could put on together, continuing with this theme of, you know, developing and learning as fellows together, where we all, let's say, present a challenging case we face in our clinical scenario related to how we have to think differently, and I think something like that would be really useful for everybody. So certainly we'll think as a group and come up with some ideas for you.
Good.
So we have a few minutes left. So I think if anybody has any other questions, I'd like to, happy to take them now. Okay, maybe no questions.
We should also remind to reach communities, because I think that awareness should be improved also in communities.
Definitely. Yeah. Of course, this is, so there's a physician part, and then there is the public sector, the everybody else. So it's amazing. But I love this journal club. I love to see how we could get you guys more involved and more connected. This is fantastic. Thank you so much for inviting me. I love it. I love to be here. And invite me again. Let's do some tough papers.
Okay, we'll find some suitable papers, and absolutely, we'd be delighted to have you back. I think now's a perfect time just to once again say, on behalf of all of us fellows from both here in Italy, but also all around Europe joining us today, a big thank you to both of you, and for joining us, sharing your insights, and really inspiring us on this topic. I have to say, really, genuinely. So big thank you. We look forward to welcoming you both back again. Giulia, thank you again for a great presentation and a summary of this topic. And so have a wonderful...
Until we meet in person in Gizeh, right?
Yay!
So have a good evening, good afternoon.
Good luck to Italy. Good luck to Italy.
Thank you very much.
Tomorrow.
Ciao.
Ciao, thank you.
Ciao.